3, 2, 1. Liftoff.
Welcome to the Ketamine Startup Podcast. This is where we talk about how to start a ketamine clinic, how to market it, and more. In this episode, Sam interviewed Dr. William Bianchi, an emergency medicine physician and founder of Maverick Medicine in La Jolla, California, where he provides data-driven, evidence-based ketamine infusion therapy. In this conversation, Dr. Bianchi shares his unique path through medicine, his transition out of the Navy, and the inspiration behind his venture into ketamine therapy. Let's dive right into the episode.
Welcome, everyone, to the Ketamine Startup Podcast. We are so excited to have Dr. William Bianchi here on the episode today. He's an emergency physician and has his own clinic in Southern California. It's called Maverick Medicine. Will, for those listeners and viewers who don't know who you are, tell us, who are you?
Thanks, Sam. Nice to be chatting with you here today. Yeah, like you, I'm an emergency physician. I practice actually on the island of Coronado, where I'm the medical director of a small democratically run group there of about 20 docs. We're a tiny ER. We're about 8 beds. But we're definitely the busiest in the county. It's been a pretty interesting time working there. But I got out of the military last June after about 12 years with the Navy. And I actually, while I was on a combat deployment to East Africa, I had a little bit of downtime. And that's actually when I made my way towards you and initially learned a little bit more about ketamine and ketamine clinics and the intricacies of how to do this type of thing while I was living in literally a Connex box, storage box, stacked 3 high in the middle of Africa. So it was a really nice way to have some time for personal study, but I might have been at one point one of your most remote students. You probably didn't know that, but I was pretty far away.
You participated and you were totally engaged. So you were living in a box? Did you say what was the name of it?
Like a Connex box. Yeah, those big like kind of metal storage boxes that you see. The military has a big kind of counterterrorism base in Djibouti where they make dorm rooms out of these things. They're easy to put like an AC unit on and stuff. But while I was on this deployment, I was doing a year-long study at CIIS, a psychedelic school, a research certificate actually, in San Francisco, and then coupled that learning with your course and just tried to see everything about all psychedelics. And then I did a deeper dive with CIS on just ketamine, which, as you and I know, we've been working with in the emergency department for a long time. And this was all occurring during the COVID pandemic, where on the emergency front, we were seeing tons more people in the ER, a lot of mental health access problems, substance use problems, and depression. So that was my motivation for pivoting a little bit from emergency medicine.
And that's really cool because as emergency physicians, like both you and I are well versed with the use of ketamine, typically for procedural sedation. But of course, we're using it off label with our clinics. What was there like a turning point for you when you were like, hey, I'm stepping out of the Navy, finishing up that, and you're the medical director. What was the shift for you? Was there a specific transition point, or was it more of a gradual process for you?
Gradual. I think much like you described just in my communication with you, the emergency department has a lot of challenges. We have lost more and more autonomy as emergency physicians with just the trajectory of healthcare. And I had a craving to want to help my patients that I've seen in the ER with mental health complaints a little bit more beyond what we provide as emergency doctors, which is really just you get admitted to the hospital or do you go home with resources to follow up? And it's just very underwhelming as an emergency doctor. You feel hopeless and helpless for your patients because there's really not much to offer there. And so as I worked to transition from the Navy, I was seeking some autonomy. My wife, similar to yours, is a physician, and this was an opportunity to practice with her a little bit because we studied a ton in medical school together. And she was my senior on my pediatrics rotations and stuff like that because we were at 2 local hospitals that were right next to each other. So it was a way to have that autonomy, have my own practice space, work with my wife again, and most importantly, provide care that I really wasn't able to provide as an emergency physician at a time when there was a lot of other factors that just seemed to prevent us doing what we do, just all the volumes and the lack of resources and I could go on and on about CMGs and contract management and private equity, but I'll pause there.
It's interesting because I believe I used to work for a company called Envision, and that's one of the large corporate management groups out there. And it was very different experience than I had envisioned working for Envision versus working for myself. I think there's this autonomy that you had mentioned of just having our own autonomy as a doctor. It's really unique because the vast majority of physicians, I think, are employees, and stepping out of the comfort zone, doing our own thing. That takes a lot of risk and courage. So I'm curious for you, Will, what were some of the unexpected challenges that you faced when setting up Maverick Medicine?
Yeah, that's a great question. So I was lucky enough to come from a background similar to you, where we had been using ketamine for a decade in the emergency department. So I had a familiarity with the medicine, which I think is really important because ketamine is very different from low to moderate to high doses, the applications, even just the route, not even touching on things like set and setting. It was nice to come in with that. This was my first entrepreneurial endeavor. And you touched on just having that confidence, being certain with your why, and trying to figure out like how exactly you want to do this in a way that isn't just replicating what someone else is doing, like really is yours. Took a lot of very intentional focus. I sat down, everyone has their own way of planning through things, right? And I was a research director for a long time with the Navy. And so I'm a clinician scientist, and I read all the papers similar to you. And so I sat down and I wrote my own research paper on ketamine, about 20 pages, just looking at all of the papers and seeing where the science was and seeing what the applications was, and then doing a deeper dive onto the larger field of psychedelics and trying to figure out what part of this fits, what part of it doesn't. And there's just a lot of unknown in that moment, because as physicians, Western trained physicians, it's if the troponin's high, do this. And then it's a little bit more protocolized. So I think that was a big challenge, and planning for overhead and finding the right space and opening the right clinics. I mean, those are all challenging, but I think nothing can really understate the feeling you have when you're like, it's go time. Like I start my own IV similar to you, and that's traditionally a nursing role. And so that I had a lot of stress and anxiety about throwing a 24 in the back of a hand. And what if I need to use my ultrasound? And so that was a technical component that was a little stressful, but also just making certain that you are providing excellent care. And for me, in an evidence-based manner for someone that really needs your help in that moment, in a shop that you've created, in a clinic you've created, just felt like such a tremendous amount of pressure. Like going to work as an ER doc is like playing on an NFL team. It's like another game, another day, got to get through the shift, got to do the things. It's entirely different to go and play in a place that maybe you built the stadium from scratch, and like everything that's there is because you put it there and have thought so much about it. So you just, I think I underestimated in my mind, like how emotionally invested I would be when it came time to actually work in the environment that we created.
It's really running and being the captain of your own ship when you start up your own clinic, because you are literally the CEO, you're the medical director, you may even be the nurse, you may wear a lot of hats. And in a way, with the autonomy and the freedom also comes responsibility, because it's like, hey, when I used to work for the ER, like, yeah, I was responsible for the patients, but not necessarily, hey, ordering the supplies or hiring the right people. And so this is almost like you are literally the captain of your own ship, and it can be challenging. So I want to touch upon the IVs, because we don't put IVs in the emergency department. It's always the nurse, at least at my shop when I used to work. It was, hey, they'd have the IV in place. They would have all the blood tubes drawn up, and they're like, hey, Dr. Ko, what do you want to order? So for you and that specific challenge, like how did you get better at IVs?
So that's a great question. It's funny, right? Because we go through medical training as students. You might do an IV or two, residents. Yeah, but like you're practicing very big things that go into necks or groins to resuscitate people. Even some of my combat training, it was focused on just a very different scenario where you're not trying to do something that's very nuanced and making it comfortable for the patient and not very anxiety provoking. That's not always like the frame of reference in a trauma bay. So I was honest with myself, and I chatted with my wife, and I was like, I think I'm pretty out of practice with these. And she said, why don't you just go to shift and tell your nurses that you want to just start every single IV that shift. And I was like, that's ridiculous. No. But I did. It was very humbling. And they thought it was just so funny. I was going to go in and they were going to watch me place all the IVs. And I just told them it was, for practice. But you learn a tremendous amount by doing it on patients that might not be super, super sick. As ER docs were asked to do them with an ultrasound on really sick patients, which are inherently difficult. But with a little bit of practice on patients that aren't necessarily acutely ill, you learn a ton. A lot of nuance, just even about the IV itself. We have at the shop I work at as an ER doctor, and also now in our clinic, the bloodless IVs, the auto guards that have that nice little plug. Whereas in the Navy, they have the cheapest IV possible, and you put it in, and inherently the patient was bleeding all over the bed, and it's just, it's an ER, it's a mess, it's the military. Put it in my mind, I was like, that is just not at all congruent with a relaxed and peaceful therapeutic ketamine journey. Yeah, just practice and then bringing it into the clinic. But still, there's, like you touched on, there's something different about working on your own ship. There's just a little element of extra stress there the first few times.
Yeah, absolutely. And I loved how you practiced in the ER before you may have started on your patients. Because when I first started, I was actually scared of putting in my own IVs. So I asked a nurse to help me and hired her part-time, but it was not reliable hours. So eventually I just had to get good at it. And again, like you, I just practiced. I didn't put them on every shift. I would do 2 to 3 IVs for the ER patients. And it was funny because the nurses loved it. They were like, hey, doctor, you want to put in the IV for me? Go for it. And as a matter of fact, why don't you put on this other little thing and draw up some blood too while you're there?
Grab a urine.
I grab the urine, the golden urine. I'm always waiting for the urine. It's like, why is that test not back? That's hilarious. I'm curious about, just to rewind, and I want to know more about like your history. So tell us like maybe, and this is a shift in gears, but I want to know more about you. Is like, where did you grow up? Where did you do undergrad, college? And then how did you transition into the Navy?
Sure. Yeah. So it's funny, like the last thing I wanted to do was be a doctor, be in the Navy, because my dad was a Navy ENT, or ear, nose, throat surgeon. So I grew up in Maryland and got into UC Santa Barbara for engineering, electrical engineering, and hated it. Wasn't killing it with the math and the physics and the differential equations, the integrals. And I started to ride ambulances for AMR after taking the EMT class in Santa Barbara. And I was like, this is awesome. I love the medicine. I love the patients. Ended up switching over to biology and studied some music. But the idea of medical school wasn't until the very end of college for me. So I took a non-traditional route. I was a neuroscience researcher for a year at UCSB, became a firefighter, swiftwater rescue technician, and then eventually a paramedic on the East Coast in Maryland, because we have a nice career volunteer system out there where the training's free. I was like, oh, this is great. And then ended up doing a master's at Georgetown to prepare for medical school. I met my wife. And we took one more year where we both went up to Johns Hopkins, and I did research in emergency medicine. She did her research in pancreatic cancer. And then we got into med school together. So we went down to Florida for 4 years. And at that point, it dawned on me like, oh, maybe the Navy could be an exciting adventure. It's, the fire rescue department is very paramilitary. And I started reading about Navy medicine. And of course, at that time, we were still at war in Afghanistan. And the idea was like, this could be really interesting. If I was a physician in the Navy, it might be really impactful. You can go out there and save some lives. So I signed for a program that it's called the Health Profession Scholarship Program. I'm sure some of your colleagues did it. They'll pay for medical school tuition, give you a little stipend, pay for your books. So I was a reservist in medical school. And then when I came on active duty as a resident, I went to residency at the Navy hospital that's in Virginia, Portsmouth. So my wife trained as a civilian right next to me. And after doing a 4-year residency program there, I got orders to San Diego at the big Navy hospital out here. And I was the director for combat trauma research for those 4 years. And once you're active duty, you have to deploy. I was slated to go a couple different places, and then you mix in a little bit of COVID and things got crazy. And then also the Afghanistan war ended. I was fortunate enough to spend all 4 of my years at San Diego, two of which I was technically attached to 1st Medical Battalion in Camp Pendleton. A lot of interface with special warfare groups, people exposed to combat trauma sequela that had a lot of mental health implications and manifestations. And so my interest started in combat trauma, things like tourniquets, medications like TXA, all that stuff that we learned in residency. I think shifted towards the field of what I perceive to be psychedelic medicine or interventional mental health. It's got different names right now. And that's how that kind of transition occurred. And when I separated from the Navy a year ago, I decided I wanted to pursue both. So now I'm still clinically active in the emergency department, and I'm more kind of part-time at our clinic, which is nice because it provides some dichotomy. I don't have to worry too much about filling up my schedule every single week because I'm still practicing clinically. So it's created a nice environment where I get to choose which patients I work with and the terms in which we work together. So it's a little bit, I'd say, as far as clinics, we're pretty small, we're pretty concierge, and it's a good balance. It's been a nice way to revitalize myself as a physician, because as art is just a wild place sometimes.
Totally agree. I think that was one of the nicest things about, like, for me, when I started just being a hybrid hybrid clinic, ketamine clinic owner, was I felt like when I worked in the ER, I was always like in fifth gear, just cruising, going 80, 90 miles down the highway. But when I'm in the clinic, everything slows down. I'm in first gear and I get to slow down and really take my time with my patients. And what's nice is because I was continuing to work in the ER part-time, it was that nice kind of, financial stability or cushion where it's not, super busy at the ketamine clinic. All good. I can just pick up a shift or two. So I really appreciated that.
Yeah. It allows you to just have even more autonomy. You don't feel pressured to work with a potential client where this might not be the best fit for you. If you're looking at a ledger sheet that's deep in the red, it's tough. Like, what happens? Emergency department, it's simple. Our patients arrive on these nice, brightly lit ambulances and just come in to see us one after another, even more so than usual 3 to 5 years, but very much an entirely different practice model. But keeping that balance does provide for a little bit more autonomy.
Absolutely. Because in the ER, of course, we have EMTALA. We're mandated by the federal government to see each and every patient and evaluate them. But in the private practice clinic that we own, we can actually, this might sound strange, is pick and choose who we want to work with. Because although they're coming to us, sometimes I also feel like I'm actually evaluating them to see if they're a good client or patient to work with. Because sometimes that relationship can be long, and it's really nice to be able to pick and choose in a way like, hey, who's a good fit for me and for our style?
Yeah, no, exactly. That physician-patient relationship is assumed immediately in the ER all the time with anyone, which there's reasons we went into emergency medicine, and I think it's important, but having a mix where you have some control over that relationship, I think allows for, in some ways, better medicine to be practiced, because you can be completely certain that you are aligned with that client as to what their goals are and whether or not you feel like you're going to be able to help them pursue and accomplish those goals. And you can find the clients that are going to be really motivated and want to fully engage with what you have to offer. How many times in the ER do you see someone come in with a complaint of high blood pressure? They don't take their medicines and they might even be eating French fries in triage as someone's checking their blood pressure. It's, okay, man, we'll try.
Yeah, it's beautiful. Just to go back, so you have Maverick Medicine and it's in Coronado Island. Is that correct? Or is it in Escondido?
So we're in La Jolla.
La Jolla, thank you.
Yeah, we actually used to be right across the hall from where Field Trip Medicine was. And that was a big moment in our journey where this big ketamine company backed by $75 million of private equity just coincidentally opened up right across the hall from us. And they went under pretty quick because I don't think that there's a lot of reasons why. But no, so yeah, we're pretty small up there in La Jolla. And then when I'm not there, there's a small hospital on Coronado that I work.
Got it. Thank you. And I believe, and correct me if I'm wrong, your wife is also collaborating with you. Is she seeing patients with you, or is she just doing operation stuff?
So she will, similar to how things are in the household, where she's the glue, right? I wouldn't have socks that matched or a clean shirt. So a lot of it has been operational guidance and advice. She's also a clinician similar to your wife. So if I have something I'm wondering about or a client that is maybe a little more complicated medically, I'll informally run things past her. But I'm essentially a solo practitioner at this point. It's just me working directly one-on-one with our clients And I don't have a nurse or a tech. It's just really a concierge experience that we provide.
That's awesome.
Like I said, I wear all the hats, one on top of another. So it can be a lot at times.
Yeah, absolutely. Juggling many things. And for me, Kim, she's definitely going to be listening to this and editing this. She is a physician, ophthalmologist. So she doesn't do any of the clinical stuff, but she's all into the marketing and the creative director side. And I guess it's not a curbside consult if it's our wives, but maybe the bedside consult informally, just to bounce ideas off of another physician can sometimes be useful, even though they're not making those clinical decisions at all.
Yeah.
So you were in the Navy and you just recently finished. So number one, kudos, congratulations. That is amazing. What are your thoughts on, actually, I'm curious, did you use ketamine in the military when you were in the Navy? Were you administering it for all sorts of stuff or not that much?
No, definitely. I mean, military has emergency departments similar to civilian ERs. So you use it there all the time for pediatric sedations or getting the shoulder back in place for a young sailor or soldier. We teach our combat medics, Navy Special Warfare medics, something called tactical combat casualty care. And very, very interesting topic that probably is off the course of this podcast, but ketamine is one of the combat medications that we treat combat casualties with. The nice thing about it is it's relatively easy to dose. It's small, concentrated, and portable, so it can be on a plate carrier. The psychiatry literature from the military medicine background is very interesting because they're finding that fully dissociating a wounded warrior with ketamine is obviously going to provide pain control without affecting respiration or heart rate. But a secondary effect is lessening the sequela of a medevac or being dragged 200 yards with bilateral extremity amputations and tourniquets in place. You're essentially preventing them from a psychiatric mental health standpoint from experiencing a lot of the sequela of the trauma of their traumatic injury. And there's just a lot of interesting stuff happening right now with TCCC or the Casualty Combat Care. And so we use ketamine all the time in the military, especially on the battlefield. A lot of really novel stuff like oral transmucosal fentanyl lollipops with a rubber band, attach it to a plate carrier, tell the wounded warrior to place it in their mouth, don't chew it. And when they have enough fentanyl on board, their jaw goes slack and the blood pop comes out of their mouth. And so self-titrating, when they wake up, if they have more pain, it's right there. So things like that, combat applications of ketamine are really interesting and have been built on, especially over the last 20 years that our country was at war.
Yeah, I think there was an interesting study where they were using ketamine for, and I forget whether it was Army or Navy, but for burn soldiers who had experienced burn and they were in the burn unit. And if they had received ketamine, then they noticed there was an association with decreased rates of PTSD amongst those who had received ketamine. So it reminds me of what you're talking about, the long-term sequelae of some of the intense events and trauma that they go through.
Totally. Yeah. Burn scrubs, which as you and I know, is a long, many weeks long process. If you are using like a Versed fentanyl combination, you might not care as much about the pain that's occurring, but you are still lucid. You are still living that experience. It's really interesting research. If you can incorporate some ketamine and lessen the trauma of the experience for the patient, they're going to heal physically and maybe have less challenge on the back end.
Yeah. And there's a lot going on in the psychedelic space and the military. Like, for example, I think there's an organization called the Heroic Hearts Project, where they're taking veterans who have PTSD and administering or taking them to various retreats and psychedelics. And you and I were both in the state of California. There was a bill, I think it was SB 58, that was like pretty much legalizing psychedelic therapy, but that got denied by Governor Newsom sometime last year. What are your thoughts on either psychedelic therapy or ketamine therapy in the military population after their service?
Yeah, that's a really good question. You're asking it at a very tumultuous week time, right? So the FDA panel obviously just met last week to review the phase 3 clinical trial data from Lykos Therapeutics, formerly MAPS, looking at MDMA-assisted psychotherapy. And they voted against recommending to the FDA to approve it. And the final FDA approval comes this August. We're talking in June for anyone listening to the podcast right now. And they overwhelmingly said the science really isn't there to support this right now. And for me, this is something I've been really looking forward to for a long time, because I see what we're doing with ketamine as just the beginning of a much larger field of medicine, where 20 years from now, hopefully, we're looking back and we're seeing multiple psychedelic medications used for multiple different indications. And this presentation to the FDA was a culmination of about 30 years of research. And as a physician, as a clinician scientist, the hearing really uncovered some very fundamental issues with the data that they had provided. Not to dive too deeply into it, but there were issues with blinding. Obviously, it's hard to keep the patient and the clinicians blinded to whether or not a psychedelic was given. People know when they get ketamine, and they know when they get sane.
Yeah.
So that infuses bias. The same is true for MDMA. And there was some issues with who they recruited, who had experienced MDMA before recreationally, and some issues with safety data that wasn't necessarily obtained at the time of the trial, just to touch on a few things. And so, although the data from the phase 3 trials was really encouraging and very promising, especially for veteran patient populations, but not even just them, police, firefighters, healthcare workers, people that have inherently mentally traumatic responsibilities in society, it was a positive signal that they had to be walked back because the science wasn't as strong as we had hoped for it to be. That being said, I think this is a really exciting time, because if you're like me and you nerd out and listen to the whole 8-hour C-SPAN thing, the fact that FDA is even entertaining this modality and that they're really looking at the literature and the science this deeply is amazing. And there was a lot of positive comments about this being a very promising modality for PTSD, which is difficult to treat. So that's tremendously encouraging. And this might just represent a little bit of a scientific setback or delay until a couple more data points are secured. But it's a very exciting time nonetheless. I think that things like ketamine and some of these anecdotal case reports that you're reading from some early clinical research are awesome.
I love your positive outlook for that, because I didn't even think about, hey, at least they are considering it and really looking at it. One of the things that surprised me about the whole hearing was they were on phase 3 studies. And I was like, why didn't they mention it when they were in phase 1 and phase 2? Hey, maybe you guys should include some of the LFTs and kidney function. Maybe you guys can add in a active placebo, or maybe you can standardize the therapeutic protocols. I found it surprising that they didn't give them the feedback as they were passing each phase until the final finish line. And they're like, by the way, you didn't do X, Y, and Z, and that's why it's probably not going to be passed. And it may be, because I know that the official FDA, they haven't made their final, as of this recording, they haven't made the final ruling. So there's a small chance. But I was curious. I was like, why didn't they just mention it previously before they got to near the finish line?
Yeah, there's a lot of questions. I trained with MAPS and know both Annie and Michael Lidofer, and actually I was able to get Rick Doblin out to give a talk at the Navy Hospital here in San Diego, grand rounds for the psychiatry department. So they've been working really hard, but they've been doing tons of research for decades, just incredible stuff. But let me tell you, coming from a research background, IRBs, those are beasts to get through with clinical protocols, lots of money involved.
True.
And they had multiple clinical sites doing this research. And even just a small change to get like an LFT, while it sounds very easy, maybe that was a limiting factor. I think that there's also just some inherent limitations to doing research in this space that I don't know if there is a good solution. Like, what do you provide as a similar placebo, like a dose of IV Precedex? It's hard to, so there's some inherent scientific challenges as well. Yeah, there's a lot of questions. There has been for a long time, but I think they're really starting to narrow down, and science moves very slowly.
Yeah, you bring up a good point. I give kudos to MAPS, aka Lycos now, because to actually do the research, like you're saying, to go through these IRB approvals. I remember I was just doing a small little mini research project. It took 6 months, 9 months just to get the approvals, and they were doing these large multi-center studies. So I guess, yeah, you're right in that making these small changes may have even delayed it even further with the data collection. So I can see that now. I want to hear more about your clinic. You had mentioned it's this concierge kind of private practice, small, you're the main person doing the whole thing. Like, tell us about your style. Like, what's the way you do it that may be different from another clinic?
So every clinic is different. You do a great job of describing like the spectrum of ketamine and indications and treatment approaches. I think that the Ryan Haight Act and the laws that changed with COVID caused this huge explosion in the field of ketamine for mental health. And the oral lozenges that were being mailed out, that are still being mailed out to five or six different companies that are out there, was really concerning to me. I feel like it was just like a matter of time until the Mr. Perry story kind of came out and got the press coverage that brought it to everyone's forefront consciousness. So I found all that to be very concerning as I stepped into this field. And so I really looked super hard at the literature, and there's the CanMat meta-analysis recommendations, and also the APA that published, I think it was back in 2017, that I gravitated towards. And I looked at the RCTs and the meta-analyses, and I was like, okay, if I'm going to do this, I want to do IV ketamine only. I don't want to be having people doing lozenges or just pieces out there doing rectal ketamine or muscle shots ketamine. I want to do what the research is, and about 90% of research is IV. I want to do it in optimal setting, a demedicalized clinic that looks nice and feels comfortable. I want to do it in accordance with what's been researched. So I want to follow 40-minute infusion protocols. And I really want to optimize this with good EMRs and augment it with appropriate psychedelic music and just all of the variables one by one out of it. And then the last thing I did was determine that I wanted to focus only on treatment-resistant depression. There's a lot of different applications for ketamine, but I was most convinced by the research there. And I also just felt better knowing that I'm going to do a deep dive on treatment-resistant depression, and I'm going to be very familiar with who responds and how to do it well. Just one medicine, one way, one indication, we'll start there. And I found that I just stayed there because the few clients I've worked with that have had some of the other indications, the results have been a little bit less predictable. And I've found that some of the more pain indications, things that require longer infusions, deeper infusions, are a little bit harder just for me to coordinate professionally, just because I am still working in the ER. And then the last element to it was doing things on the terms that I would want if I was a client. I'm probably the least efficient of anyone out there doing this stuff. I meet people for a 1-hour intake after we chat by phone. So there's like a 2-tier interview process really. And then we work together after making certain it's a good fit both ways. And so our appointments are very long. So it's a 2-hour appointment for an infusion. So we just have plenty of time to check in, do the infusion, and allow for a nice recovery. So it's not the most efficient model because 4 infusions in my day is full because it's really just one room and it's just me. So I'm on the far spectrum of probably doing this very slowly and not very efficiently from a business standpoint. But I've found that intention with each of my clients and each of my infusions has been really gratifying, and something that a few months we've been more busy and it starts to dilute that a little bit. That's how our approach is. It's not to say that anyone that's doing this for other indications or in other ways is wrong. They're definitely not. It's just that everyone has their own approach, their own background that they bring to this. And the clients that we work with oftentimes are from backgrounds that I resonate with, military backgrounds, fire rescue, healthcare backgrounds. And it just allows me to give them my undivided attention and really full clinical awareness, which is hard to do if you were to have 2 rooms, keeping both full. You got like nurses and techs and stuff, which we might expand at some point in the future too. We're just going slow and really, most importantly, having fun. That's all we got.
Wow, there's so much beautiful things you stated there, and in particular about being inefficient. Sometimes this medicine and in this space, like efficiency is not the goal. I know when I worked in the ER, that was the goal because there's 30 to 40 to 50 patients. But with ketamine therapy or psychedelic therapy, like trying to see as many ketamine patients as I can, like at least for me, and it sounds like for you, that's not really our intention or goal to like have 10, 20, 30 patients a day. It's, I just want to focus on these patients, do the best job I can. It may be slow, and actually tell our patients and our staff, like, here at our clinic, we practice slow medicine. And so we do everything slowly. And some of the staff members who have worked at other clinics, maybe not in a ketamine clinic, but at other dialysis or ICU, like they're stuck in a way or habituated to be moving fast. And I say, no, we're the opposite here. It's very slow. It's inefficient. And I think you bring up a really good point about, it's okay to slow it down and really focus on one patient at a time.
Yeah, that you touched on something there that it's inherent to our ER training. It is all about efficiency, emergency, and this is almost, and maybe that's why I've gravitated and enjoyed it so much, is it's the antithesis of that, like provide that yin yang kind of type thing. And so maybe inefficiency is not the best word. Maybe it is really actually clinical efficiency for the patient, for the indication for what we're doing. But maybe that's just our Western trained ER.
That's a good point. It's very efficient for that one patient because they may have been dealing with decades of depression. Yeah. And the other thing that stands out to me about what you were saying, Will, is like how you really picked one focused area, specifically TRD, treatment-resistant depression, and really narrowed in on that spectrum. And I know other clinics, they'll treat all sorts of indications. And I know other clinics who just specialize, like there's one physician in the LA area, and all she does is, not all, but 90% is like CRPS and anything central sensitization related, CRPS. And that's really her one niche that she uses ketamine therapy for. And she was on a previous episode. And I like that because then in a way it differentiates you from other clinics who may be offering ketamine for 10 different conditions, but really niching. I think that's the key, especially when we're starting out. And I've mentioned this to you before. It's like going to a restaurant and going to the one restaurant who's, hey, we're really good at burgers. We make the best burgers. We get grass-fed Kobe burgers from Japan or Brazil or wherever. And these are the best burgers. We don't care about pasta, sushi. Like we just do one thing and we do it really well. And I think sometimes those restaurants are better in a way because they're like, hey, we're really good at this one area. We know everything about this in this space. And I think that actually adds a lot for the patient.
If you tuned in to our episode today, chances are you're curious about the ins and outs of starting up a ketamine clinic. It's an exciting field, but let's face it, the journey from idea to actually opening day can be quite daunting. That's why we've created something special for you. Think of it as your personal roadmap, a free downloadable checklist that lays out the essential steps you need to consider when starting up your ketamine clinic. This checklist is designed to help you avoid common pitfalls and launch your trajectory to success. So how can you get your hands on this checklist? Simple. Just visit www.ketaminestartup.com/checklist and grab your free copy today. We've made it easy and accessible because we believe in supporting our community with a valuable resource. ketaminestartup.com/checklist. All right, let's get back to our discussion. Stay tuned and don't forget to download your free checklist during or after the podcast.
Tell us about one of your patients. Like what's one patient that stands out that you've treated that you're like, oh my goodness, I can't believe this was so efficient for that person.
I don't want to jump into a specific patient because we get to, what's cool about what we do is you learn about your client on such an intimate level. You get their whole life story, really get to know them over the multiple infusions. And also you get to know their families that might be coming with them. I think to answer your question a little more broadly, I really enjoy working with clients that have a similar background to me, that have never had any type of mind altered state ever before. I recently started working with a client that has never had alcohol, has never smoked marijuana, has never had tobacco, and definitely has never done any recreational drugs to include ketamine. And embarking on like an induction series with those types of clients that are stuck where they're at, but they're curious and they're hopeful and they're ready to just jump into this with you is super cool to me because you are like giving them a new perspective into a realm of consciousness that they've only ever heard about or read about. They haven't done any self-experimentation. And so you get to provide this therapy in a way where you're going to give them an amazing experience. And most importantly, they're going to have a great clinical outcome Whereas someone that's maybe experimented in college or has had really rough history with substance use comes at it with a little bit of trepidation or worry or anxiety. And you get to just work with this a blank psychedelic slate, I guess I could say. So I really like working with some of us use the term psychedelic naive, or psychedelic inexperienced. Those types of patients are fantastic.
Yeah. And broadly speaking, has there been any patients that you've treated that has been more challenging, or you're like, oh man, that one was a tough one? And you don't have to get into the specifics, just for patient confidentiality.
Yeah. So everyone comes from their own background. And I think I've been fooled a couple times, right? I've worked with people with police backgrounds where imagine having a career where you're like, your job is to fight the war on drugs, but you've had a very traumatic career and things have just been really difficult. And maybe you found yourself at a place where you have treatment-resistant depression, but you've never considered anything like ketamine therapy because you bring your own frame of reference to that type of thing. People that just have their own preconceived notions about what it is that we're doing and what we provide. And so I've found that I always have a little bit of, I don't know, just hesitancy when sitting down to meet and work with those clients. But I've always been pleasantly surprised on the back end where they do it a few times and I'm like, I get it. I feel better. This is awesome. So I think it's mostly been in my own mind where you don't know what you don't know. And you think, oh, I'm working with a retired detective, or I'm working with a really conservative guy from the Marine Corps, and you embark on this journey with them and you're like, they're pretty open-minded.
Yeah.
I didn't see that coming.
Given your clinician scientist neuroscience background, I'd love to hear your thoughts on what do you think is going on in the ketamine experience for the patients? Because, we know biologically it's an NMDA receptor antagonist blocking activity of glutamate and affecting the 5-methyl-D-aspartate receptor and all that jazz.
Yeah.
But from your experience in not only delivering it in the Navy ER, but now with patients in your clinic, what's your thoughts? And you can just hypothesize, I don't know, what are your ideas on that? What's going on there?
Yeah. I was talking with a friend about this. When we go through training and you learn about ketamine as a physician, you just learn indications, contraindications, allergies, what to do for laryngospasm, all the medical stuff. And then once you start practicing clinically, you start to realize this might not be the right patient that I want to give ketamine to. They're in a wetsuit after dislocating their shoulder from surfing, really anxious. Their mindset is not good for ketamine right now. Maybe I'm going to use a different medicine. And then once you start working in clinic, you start to realize, wow, I control the setting and I'm controlling the dose, but the mindset of the patient is really important too. You start to see that the lower doses, because similar to you, I work within that 0.5 to 1.0 milligram per kilogram dosing. The lower doses almost seem to be more emotional journeys where a lot of my clients that have maybe some unprocessed trauma, that'll come up on their first few infusions. And so I think the lower doses are important to get people comfortable with the therapy, comfortable with kind of the experience. But I find that the content of their journeys, their psychedelic experiences, tends to have a lot of meaning. And then as you increase the dose, approaching that, some describe it ego dissolution or dissociation, those higher doses, usually it's 0.7 to 0.8 for a lot of my clients. That's where it's just they're relaxed. They're on a really immersive experience. There might not be stuff like childhood trauma or other things in their mind that are coming up at the lower doses. And in that moment, I really think those doses are much like a forced mindfulness meditation, where the mind just gets a break from rumination, the way of kind of processing, because really consciousness is amazing, right? It's just our brains interpreting stimuli to create a reality so that we can crawl around on this world and, get food, not die, stuff like that. And that moment at those higher doses, I think is a forced mindfulness where there is. And so I think I really like that snow globe analogy where they talk about shaking the snow globe upside down and all the neuronal tracks start fresh again. We could nerd out on all the science and the BNDF and the prefrontal cortex and the GABA and this and that. And we really don't know ultimately at the end of the day. But my gestalt after working with ketamine for a long time is that those higher doses really provide a lot of relief to people that suffer from rumination and depression, and especially suicidal ideation. It's amazing for that. So that's just my gestalt, though. That's just my experiences.
Totally.
There's other clinicians that are out there. They're saying full dissociative experience is really important. And I think that there might be some indication for that for some patients, but we're all really still figuring this out. And the science, we're really practicing right at the forefront, to be completely honest. There's a lot to be learned. We didn't even have CPR before the 1970s when you think about it. Isn't that amazing? People just dropped to the ground and we didn't do CPR on them because we didn't know what it was. Emergency medicine wasn't a thing until the 1980s.
You're right. Yeah, you're absolutely right. It feels like we've been doing this for a long time, but in actuality, like in the grand scheme of things, it's literally a flash. And
Again, similar experiences with the doses of ketamine for mental health implications.
Yeah, like you, I think one of the things you highlight is customized dosing, right? Because even though there's a range, every person is going to respond differently. Like the standard dosing is 0.5 mg per kg in a 40-minute infusion. I've given that dose to someone before, and that patient had a 20 out of 10 experience. We actually had to stop it early because it was way too strong for this patient.
Yeah.
And so I was like, okay, 0.5 is too strong. So I'm going to even go lower. I did 0.4 mg per kg, and that was too strong. And eventually I did 0.3 mg per kg, and that was the right dose for her. I was like, oh, this is interesting. I know the data shows 0.5. But for this individual, it was 0.3 mg per kg with tremendous results. And so I think recognizing that every person is going to have a different, I call it the Goldilocks amount. Some people need a higher dose, some people need a lower dose.
Yeah.
And I think it takes that clinician judgment to know, as well as multiple infusions, to see how they tolerate it and what their experience is like.
Great point. Yeah, great point. Yeah, I've had the opposite too. We'll give like 0.5 and people will come out and they're like, what's going on? And they need more.
Yeah.
Just to have that range to work through. And that's really where that physician client relationship is paramount, because it helps you figure that out.
Totally. And I've had patients who go, this has been surprising, where they need higher doses than 1 mg per kg. Sometimes I'll go 1.2, 1.4, 1.5. And so I will titrate it upward, because there was a study done by one of my colleagues, and he was looking at, I believe, veterans and for PTSD. And I think some of those patients were getting like 2 mg per kg IV. So it gives me comfort to know, yeah, someone may need a higher dose, someone may need a lower dose, but I'm going to use my judgment as well as vital sign monitoring to make sure it's safe for the patient. Based upon your experience, and now you're open, you've been doing this, what's one piece of advice that you would offer to someone who's maybe thinking about it? Maybe they are working in the hospital or in the ER or in the OR. Like, what's one piece of advice that you'd offer to them if they are interested in starting up their own clinic?
Sam, something that you, I think, did really eloquently in your course and in what you do with a lot of your teaching online is citing that Simon Sinek video, that start with your why. Starting with your why, I think, is the most important thing, because this is hard stuff. Going from working in an ER where the lights are paid for, the supplies are always stocked, the patients are always there, is a big shift to doing something independently. And I've had several colleagues that have heard what we're doing and have heard of you as well. And everyone sounds cool. Like, I want to do that. Man, quit my job, open my clinic, do things how I want, become a bajillionaire in a year. Things could not be farther from the truth. And the only thing that's going to sustain you, I think, is coming back to why you're doing what you're doing and reminding yourself, because that's going to be what you go back to every time you encounter an obstacle. And without that, you're going to have a lot of obstacles. Both you and I know that. And you're not going to be able to conquer them all. Or if you're a hard charging physician, like you've been for all your career, you might just get stuck at an obstacle and not be able to get past it or beyond it. And that might just cause a lot of undue stress and dissatisfaction, which is really the point of doing this type of work. We're all doing this to help people, to help ourselves, to practice in a way that we want, that we're proud of, that we find satisfying. So that Start With Why lecture is really fantastic. And I think it opens up that perspective of what you didn't know. And it's hard. There's a lot of stuff on the internet, a lot of slick marketing, a lot of things that make you think this is just super easy stuff. But I think just keeping an open mind, reading voraciously, staying on top of the literature, all that's like really important. But that thing you come back to is, why am I doing this, man?
100%. And I agree with that, starting with the why, because that is going to get us through those crucial challenges and obstacles that, you're going to face. I want to ask you some rapid fire kind of fun questions as we
Sure.
sunset the interview. Let's see. You're juggling so many things, Will. You're the medical director, you got the clinic, family. So after a long day, whether in the ER or in the clinic, like what's your go-to way to just relax and de-stress?
Mhm. Depends on the day, but if I'm lucky and the wind isn't up and there's swell in the water and the tide isn't too high or too low, and I can pick the right place to go surfing and I pick the right board to go surfing with, I try to enjoy surfing waves. I have been surfing since undergrad, and here I am 20 years later. I'm still not good, but I really enjoy getting in the water, being in nature. And if I'm lucky enough to actually catch a wave, which is hard, it's just one of those things that I get to do that just deletes everything else in that moment in time. It's really satisfying. So I need to go surfing more. The whole work-life balance, especially with these types of endeavors, is hard to maintain and hard to defend. But surfing, definitely.
Thank you. And do you have a hidden talent or hobby that most people would be surprised to learn about you?
When I was in high school, I played saxophone and had a good knack for it. My mom was like, you should pick up a weird random instrument. You'll probably get all these scholarships to school. We're going to sign you up for oboe lessons. And so making my own oboe reeds, like 4-hour lessons every week. Was terrible at it. Never got a scholarship, but I played oboe for longer than I care to admit.
That's awesome. Let's see. If you could go back in time for a day, where and when would you go and why?
Yeah, back in time, today. That is hard. That is a really hard one. I don't know if I have a great ready answer for that. I think when I look at some of the older pictures of San Diego, it was a brand new city. It would be really fun to go back in the 1900s or 1890, or even the island of Coronado before it was like sold to the military, and just see things before it's like the big city that I live in every single day. It would just be nice to see that switch. Enjoy it for
Beautiful. Beautiful. Let's see. These are some other questions for fun. Let's say that you had a billboard and this billboard would be seen by millions of people. What message or what would you put on that billboard?
Don't believe everything you think.
Love it. No, that's so true. Sometimes I think of our thoughts as like spam email, where it's, I don't know why I'm having that thought. I'm just not going to click on that link because that's a weird spam email. So it's, don't believe everything you think. And if you could not be a physician, but you had to have some sort of career, what would you do instead?
There's a lot of really interesting technology that's just popping up every single day. And we talk about AI, we talk about all these amazing new Apple Vision things that are popping up. It'd be really fun to go and like work at an Apple or a Google and be in the department that gets to see all the technology. DARPA is something similar for the military and their research, where you just get to see things as they're created and try and test it all and see what of these is going to be the next thing, like the iPad, for example, or the iPhone. I think that'd be awesome. You could just get in there and see the technology was brand new and probably not be able to talk to anyone about it, but it'd just be a lot of fun because you'd be like almost living in the future.
Wow, that is so cool. And in a way, we're already doing that, what you're talking about, or you're already doing that at your clinic, because you're definitely on the forefront of medicine these days. And as we wrap up, where can people learn more about you, your clinic? Are there any socials, websites? What would be the best way to connect if someone's interested in learning more?
Sure. So we have a website. So our clinic is Maverick Medicine, like you mentioned earlier, not Tom Cruise Maverick. This was like before Top Gun. This is more of a Maverick being an independent approach to a challenging mental health problem. So it's just maverickmedicine.com, and our Instagram is the same. And really anyone that reaches out, I try and find a time to connect with them and chat, because as I know, there's a lot of confusing stuff out on the internet, a lot of misinformation, and a lot of the wild west of ketamine. So I try and take time to answer questions, or at least point people in the right direction if they're not a good fit for us. And then I frequently point them to your website and a lot of the stuff that you made. And I think this podcast is a fantastic source of knowledge too, because all of the hard work that you put into this and all of the intention that you've put in has really impressed me as a fellow clinician. So I tell anyone interested, probably start on your website because there's just some amazing material there, and a lot of their questions I answered right away.
Thank you for that recommendation, Will. And before we wrap up, is there anything else that we haven't talked about, or anything else you want to share for the listeners that you want to share?
Oh, there's one we haven't talked about. Boy, we could probably go for hours, you and I. It's just such an exciting part of healthcare, mental health right now. It's dynamic. There's unknowns. And I think we've touched on a lot of them, but I think it's important just for anyone listening to know that this is a continuous evolving forefront of medicine. And it's something to stay current on, to stay curious and engaged with. And that's really, as you consider getting into this field, that's what's going to make you successful. That's what's going to ensure your clinical outcomes for your clients, for your patients. Just staying active and reading and treating it almost like you're back in med school, because that's really what it is. You got to learn a whole bunch of stuff, and you got to study hard, and you got to work hard. And really, that's the trick to things that I at least got from you and your wife when I was first starting out.
Thank you so much. It's been a pleasure having you on the show, and we'll see you next time. Bye.